Since everybody's beating up on Harold a little bit because he always beats up on us, I will confirm, he said 10 minutes, we send him 10 slides, and he says, well, how about that one I saw? And how about this one? And they tend to be really complex slides that take about 5 minutes to explain. So
I'm sure blame it on me.
But I'm going to go really quickly because I know it's close to lunch. So, yeah, thanks. So the Maine Health Management Coalition really has two separate kind of legal organizations. One is a private nonprofit where we do things for the benefit of our members to increase the value of health care to their insured populations. But the other is the foundation, which is a charity, and that really is about doing measurement, reporting out statewide, and educating consumers. And through those various activities that both these entities work on and some things you've heard about today, there had been a feeling, and it's kind of hearing everything that's going on today, it's the same thing, where it's great to hear all this going on, but at the end of the day, how much difference does it make in terms of healthcare spend? And so part of what Elizabeth wanted to do was lead a group of CEOs, both from the hospital systems and the payers, okay, and get them together, get them kind of focused and see if we could set some community targets that could be committed to. Because when you hear, for instance, Frank saying flat funded 10% trend, what are you going to do about that? And that's going to take some serious commitment. And so the question was, it decided to form a healthcare cost work group, and again, multi-stakeholder, base it on data, look at exactly what is driving healthcare costs, try to isolate that, and then try to come to some achievable targets. The data resource we have at the coalition is we get feeds on a regular basis from about 13 different carriers and TPAs. They get integrated in. And what I'm going to report on today is based upon those commercial claims, commercial population. But like you heard from some others, the Medicaid program for the state, about 350,000 members are going to become data members, and we'll get feeding from their claims processor. And we are also one of the 4 QECPs. So as you heard earlier today, I think Oregon's saying we'll be getting full fee-for-service Medicare claims on the entire Medicare population in the state to fold into this, to continue this work and broaden it, which we think is really critical. Things like cost shifting and understanding those kinds of things is a big part of this. So why do costs vary? And I am going to go quickly. The work group started out by listing through kind of, consensus, what are some things to look at, and try to come up with actual savings that could be done by these different kind of levers, if you could pull them. And I'm just going to really concentrate on one. I'm going to show you some costs and so forth, but 1 or 2, and then show how we put this together. But what's interesting to this, if any of you have applied for the SIM grant, the State Innovation Model Grant, and trying to get some money coming in, actually to do all those budgets and projected savings, you essentially had to come up with numbers that you expected from these things. And we spent, this kind of actually fed into that process really well, and we've had some really interesting discussions with CMS as they looked at our application and asked some questions and stuff. So what's driving cost variation in the state of Maine? And let me just get you oriented. On the left side is PMPM. This is medical, not including pharmacy, commercial claims. And across the bottom are the 16 counties of the state of Maine. And I've just kind of did a stacked bar so you can see inpatient, outpatient, and professional. And so there's a 40% variation in per person spending across the state simply by kind of the location of the county you lived in, kind of a Dartmouth Atlas type approach, geographical variation. So how can we explain this? We look at the morbidity rates, and so we look at the level of morbidity in the county, the populations along the bottom, and we look at PMPM, and you can see that PMPM doesn't track essentially with morbidity. We know this, people know it, but it's really important to demonstrate this, to set the foundations for the discussions so people, it's kind of this third party again, data source, multi-stakeholder group laying this out there so you can say, yeah, what's going on, and you can start having serious discussions about what needs to be done. Certainly, you know, the highest cost counties aren't the counties with the sickest people, okay? We know that, but you have to establish that to move the discussion forward with everybody at the table. If we risk adjust those populations in those counties, we've moved the variation between counties about the average from 40% to 30%, which you'd expect, because about 30% of the variation was accounted for by morbidity. And the thing I'll point out on this slide too is a lot of this variation is no surprise to anybody, is driven by the outpatient side, and I'll show you a slide of that in a second. So if we start trying to understand then what's left, if we simply look at the variation in inpatient spends for these counties, 70% of the difference is simply due to the prices, and I have just case mix adjusted price per admission on the bottom axis. And this actually fits pretty interestingly with Frank's comment, which I hadn't seen before, where his actuary said that the percent increase in trend, over 60% of that in the inpatient side is due to price. This really fits well, and there's just huge price differences around the state. So if you're going to attack, you know, some of the variation, clearly there's opportunities here. So, you know, one of the suggested strategies, and you often hear this, is let's reduce inpatient admissions for the chronic population if we start taking care of those populations. And doing that analysis on the data, and you know, the clinicians say, well, okay, let's say a 20% target of reducing admissions. What does that translate to? It basically translates to a savings about 3% of the total PMPM. So reducing admission, like 20% reduction in admissions for the chronic population alone is not going to be the answer for Frank's population if he's got a 10% trend. Okay, and it's actually going through all these things and putting the whole picture together, which I'll get to at the end in just a few minutes, is kind of what we're after here, to put savings together. This is mislabeled, sorry, but these lines are mislabeled. All-cause admissions are not 18 to 19%. The percent of the total PMPM due to all-cause admissions is 18 to 29%, and the PMPM portion attributed to admissions for chronic conditions in this population was about 10 to 19%. So you can see if you reduce those admissions by 20%, if the average of 10 to 19 is 15, you're taking 20% of 19 out, which is only 3%. Okay, so you know, getting realistic about how much you can save by doing these things that sound dramatic, and they are, is really important to figure out how much this adds up at the end of the day. Take a really quick look at outpatient. If we look at the outpatient costs in these populations, risk-adjusted populations, they vary by 80% per person in these states. So just a really quick way to demonstrate what's going on here, we pulled like the 6 highest volume outpatient procedures by CPT codes and looked at the variation across the states and price and utilization of those procedures, and you can see what the answer is in the box. So these top 6 accounted for about 15% of the total outpatient spend. The prices varied from low to high about, you know, by a factor of 5 to 6. The utilization rates from about 2.7 to over 7 times. And yet the differences in risk between these populations was much, much more modest, okay? Things we know, but we have to establish this to then have the discussions we need to have with the providers, okay? This is a slide, this is one of the ones Harold really likes. This is an interesting slide because it talks about, it really addresses the question of infrastructure. If you look at the counties that have 1 hospital or no hospital, 2, 3, 4, or 5 hospitals, is there a difference in per capita inpatient spend? And the answer is no. Okay, which is really interesting. This is a slide that gets us into trouble with some of our provider systems because they want to consolidate and stuff. But if you look at the research, the research shows that actually when you go to fewer hospitals, you remove infrastructure, but where does the money go? It doesn't go to reducing per capita costs. Okay. Another slide, Harold Light, and because I was I was showing you kind of regional differences, I wanted to put this in because it shows in Maine, although we did things by county of residence, people really move around dramatically for where they get their services in the state. And these just happen to be inpatient service, surgeries, what we call level 1 services. And of course, they're going to the big hospital centers in Bangor, Eastern Maine, and Maine Medical Center and Mercy down in Portland. But these are things like eye, ear, nose, and throat, arthroscopy. These aren't kind of the big complex services. So just want to remind people, although healthcare is local in some ways, there is a lot of opportunity to move around, and people are doing that in the state. So to wind it up, I think these are fairly obvious. Inpatient side, it's really about price is the biggest driver of the variation we have in the state. Outpatient is price and utilization. Morbidity is important, but it's not the driving factor in differences. And the last one, the meaningful cost reductions really require a multiple of initiatives. And the one thing, the final essential product that came out of the work group and the CEO summit was to actually achieve a 5% savings in PMPM all the way down the bottom on the right. You have to add up a whole bunch of different things. And you know, readmissions is a great thing, but you can do a killer job in readmissions, but you're not going to move per capita spend much, especially in the commercial population, simply because the overall rates are too low. Doesn't mean it's not important at the individual level, but when you're looking at the total spend, you kind of have to do the arithmetic. So.
Great, thank you.
Yeah.